Welcome everyone to Spine Time. My name is Dr. Neel Mehta. I am filling in for Dr. Roger Hartle as your host today. We are, as you know, been conducting webinars with our back and neck experts here at the Center for Comprehensive Spine Care at Weill Cornell Medicine and NewYork-Presbyterian Hospital. And today I'm joined by my dear colleagues, Dr. Eric Elowitz and Dr. Lisa Witkin. Thank you for joining me. As a reminder, Spine Time is the opportunity for us to share our passions and talk about some of the things that many patients ask us during visits in our center. We are a multidisciplinary spine center, complete with pain management, rehabilitation medicine, neurology, spine surgery, mindfulness treatment, and complementary medicine. Dr. Eric Elowitz is a neurosurgeon here at Weill Cornell, who also leads the Division of Quality for the Department of Neurosurgery. And Dr. Lisa Witkin is one of our pain management physicians who has a special interest in outcomes registries. And the topic today we're talking about is the eternal question from patients: will this treatment work for me, and how do we know? So we will talk about how outcomes tracking leads to an effective care plan. I turn it over to Dr. Elowitz and Dr. Witkin now to help us shape through this.
Yeah, thank you. This is Eric Elowitz. And it's really a pleasure to speak with everybody. And this is a topic that's certainly very important to all of us. So I really wanted to start off and talk about what is a very typical patient that we may see in the office, and how do we treat this patient? This is a 48-year-old woman with a long history of back pain, but really 2 months of severe right leg pain. And what we're looking at on the screen on the left side is an image of the MRI scan from the side. We call it the sagittal image. And if we look at the dark line, the second one up, that's a disc, and there's a slippage that's there. So that certainly may be causing some of the pain. And if we look at the image on the right, that's a cross-section through the spine, almost as if we were to slice a loaf of bread, looking straight down on the spine. And on the right side, which is actually the left side of the image, there is a cyst, call it a synovial cyst. This patient has several different issues, has chronic pain, has new right-sided pain, has a slippage, a misalignment between the bones, and a cyst. So what's really important for us as clinicians, as doctors, is to know what is causing the patient's pain. What is the person's main symptoms? The back pain, the leg pain, what can we treat? What's the best way to treat it? There's not necessarily one right way to treat this person. There are different options: pain management options, physical therapy options, surgery options. So we need to find out what the patient's symptoms are, how it's impacting their activities and function, what their expectations are, and then do what we call shared decision-making, where we discuss with the patient what are some of our best treatment options. We could move on to the next slide. So really, in order to help this patient, we need to know how are we doing, not only for the individual patient, but for all our patients. And which treatments are best for which patients. As I mentioned before, we have pain management options, rehab options, physical therapy, complementary options, such as acupuncture, and of course surgery. So what treatments are best for which patients? Also, we want to know, are we doing a good job? Are our patients feeling better? Are they having less pain if that's what they're coming in with? Importantly, even if they're having less pain, are they able to get back to do what they want to do? They're able to get back to work, or their activities restored. And finally, are the patients satisfied with their care and their experience? They may have some relief of pain, but they may not be that satisfied. They didn't have enough relief, or vice versa. They may not have had much improvement, but they're still very satisfied knowing that everything was done for them maximally. And this is really where we need to find out, are we doing what we want to do, not only for that individual patient we're treating, but for all of our patients, and how does this modify our treatment patterns? Move to the next slide. In addition to how we're doing, we need to track our patients, and we're going to talk about that, but I'm sure many of you listening know and have looked at the various rating websites online. Patients use these to rate their experience, good or bad. Many patients will look up their doctors or doctors that they've been referred to help find the right physician for them. These sites are great. We monitor these sites. I think they're important. They're great tools. We also have to realize they're not representative of all the patients. Many patients may have had improvement or non-improvement and not put their information on these sites. That's not really what they're designed for, but we need to capture that information in other ways. Next slide. I'll turn it over to Dr. Lisa Witkin.
Yes, so thank you for having us, and thank you for joining us this evening. So I'm going to talk a little bit about some of the outcome assessment tools that we use often in our routine practice. They're called patient-reported outcomes because we rely on the patient to provide this insight so that we can capture quality of life issues. So these are often issues that are very important to our patients and often cause them to seek treatment in the first place. So we want to measure pain severity, and we typically do that on a scale of 0 to 10, with 10 being the most severe pain imaginable. And then we'll also try to measure the social impacts of the pain, as well as mental impacts as well, things like depression or anxiety. Patients often have fatigue who have chronic pain, and they also often have sleep disturbances as well due to their chronic pain. And then we'll do an overall health and well-being assessment as well. And so here on this slide, you can see one of the images that we often ask patients to complete that shows a body diagram where we ask patients to fill out or color in the areas where they're having pain and describe for us what the pain feels like, whether it's aching or burning or stabbing type pain, etc. Next slide, please. And so this is a diagram, part of our intake, where again, you see the body map, and then you see the numerical pain scale at the bottom from 0 to 10. And you can see this patient on the initial visit reported 10 out of 10 or severe pain along the right leg. Next slide. And then here is the follow-up assessment. So you can see after treatment, the same patient reported a significant reduction in pain. In fact, the patient no longer has any pain, reports 0 out of 10 pain throughout. So this would be a success in terms of our treatment of this satisfied patient. Next slide.
One thing I wanted to bring up here is I can't help but notice that your previous slides show a computer version of it. And here you have it on paper. And how does that help? Does that impact how you're able to track data? What if you don't have a computer to do things?
So that's a good question. Recently, we've transitioned to electronic questionnaires and formats. And so patients can complete all of these questionnaires in the convenience of their home on a computer or a laptop or on a phone or tablet through a secure platform, through the MyChart Connect application or through the website. If they do not have access to a computer or the internet, they can always complete it in our waiting room. We have tablets available as well, or they can complete it on paper, or the physician can help them complete it in the office as well. So there are a lot of different options, but we think that it's very important information. So we want to try to help the patient complete it as much as possible at the time of the visit. And
perhaps you can share where it's most useful if they have more data completed at home before their visit. Is is there a disadvantage to doing it during the office visit?
So because of the COVID pandemic right now, we are trying to limit some of the paperwork completed in our office and try to expedite the patient flow through the office as well. And so if the patient can complete it at home prior to the visit, I think that that is optimal. It also is most efficient for the patient as well. Again, if it's not an option, we do have alternatives to be able to collect the information as well.
Yeah, I agree. Also, we would appreciate having this information up front, and that way when we review a patient's chart before we actually go in to see the patient or do a video visit, as you mentioned, we have all the information. We often have detailed questionnaires, including these kind of scans, and also going over MRI reports, MRIs, and the other information. So the more that everyone does ahead of time makes the visit more meaningful.
We have an excellent question coming from Linda G. She writes in, everyone's level of pain is unique for their body. The pain tolerance level is also unique to them. How do you fine tune each patient? And I think this is the crux of our conversation today is how do we measure beyond a numerical score, and how do you ask specific questions to tease out how a patient is doing?
Exactly. Pain is inherently a subjective experience. So what is mild and tolerable for one person may be pretty severe and debilitating for someone else. And so that's why measuring a numerical pain scale number is one component of our assessment. But I think it's really important to measure all of the other domains that we mentioned earlier as well. So all of the quality of life factors. So how does the pain affect your ability to function, your ability to sleep, the ability to do all the things that you want to do? And so we try to gather all of that information to provide a comprehensive assessment of a patient and use that in our clinical decision making to recommend the best treatment tailored to that individual patient.
Eric, you often talk about goals. Share with us some of the conversation you have with a patient considering surgery or even talking about treatments.
Really, a lot of it depends on what the expectations are. You know, patient may, I can give a couple examples, patient may have had 20 to 30 years of chronic back pain, but more recently has had severe sciatica. And I may tell the patient that surgery may address and would hopefully address their sciatica, but it would be highly unlikely to erase 20 or 30 years of chronic back pain. And would they be satisfied to get back to the way they were 2 months ago? So that's one aspect of expectations. Another is really how it affects someone, how the pain that they're experiencing affects their activities and function. So that having a numeric score, such as we see here, is absolutely important, and we need that. We also know how is it affecting a person's activities and function. Someone may be having a pain level of 6 or 7, but if they're doing everything that they need to do and they're working and working out and exercising, they may not even necessarily take a look for treatment for that. So it's really important, and I always ask, how is affecting your activities or functioning, impacting quality of life?
Shika has been asking a couple of questions surrounding the patient that we have represented here, where they've gone from a baseline of 10 to 0. And is this typical? Is this something that a patient should expect? Is it how would you comment on that?
I could answer that. I think that this is an ideal situation, the true case of a patient who had surgery, but not everybody who has surgery is going to wind up with a 0. I do tell patients that they may have continued pain, and there's no certainty with any treatment that we're going to reduce a person's pain. But if we can have a statistic of 80, 90% of improvement And again, that's meaningful, significant improvement, not necessarily going from a 9 to an 8, but maybe going from a 9 to a 2 or a 3. Does that meet their expectations? Is that something that they would be satisfied with? So it would be great if every patient went from a 10 to a 0, but I always want to be realistic when we talk to our patients.
And I agree, and I think for non-surgical treatments, we use a similar scale. We may not see complete relief of the pain, but if we see improvements that are meaningful for the patient and the ability for the patient to function in an improved manner, then we consider that successful.
Great. Well, I know you've spent some time putting together some really interesting graphics that I want to share as well. Perhaps you can walk us through this.
So this is just a screenshot or an example of what the electronic questionnaire looks like from the patient. So you see, this is our PROMIS questionnaire, so patient-reported outcome, and this is specifically looking at the patient's ability to participate in social activities. So you can see the question here, I have trouble doing all of my regular leisure activities with others, and we ask the patient to answer this question, how often this appears, how often this happens, and then the next question will appear in the survey. Next slide. So the output of the questionnaires provides significant, important information for the clinicians. And so this is an example that we see after you've completed the questionnaires. And again, you can see on the initial visit, patient reports pretty severe anxiety, as well as a pretty significant interference of their physical activity due to their pain. And over time, we can track these things, and over time, they both improve. So at the second visit, now the patient only has mild symptoms, and then at the last visit, you can see they're back to normal. So we can see significant improvements in a lot of these areas. Next slide.
It's really interesting. So here you're showing in a numerical validated scale, right? Perhaps you can take a moment to explain what PROMIS stands for, but it appears that these are things that can be applied to a broad population and you can use as a comparison against other people. Is that fair to say?
Exactly. So PROMIS, again, is patient-reported outcomes metrics information system. And so it's validated and useful information for the patient that we're seeing today. And then we can also use this data in a de-identified and secure fashion to build a registry of all of the patients that we see in our multidisciplinary spine center. And so this allows us to better treat the individual patient that we're seeing at the time, but also to learn at a population level how to better treat spine patients in general. So to learn which patients may benefit the most from what treatments.
That's great. Maybe that's a good opportunity to share some examples of when you have learned something from this and then change your practice. And perhaps both Eric and Lisa could answer that in your respective practices.
So example I could use is something similar to this slide here. So we often see that patients with chronic pain suffer with depression or anxiety and have sleep disturbances with their chronic pain as well. A lot of the medications that we can use to help manage chronic pain, particularly musculoskeletal pain or nerve-related pain, are in the class of medications called antidepressants. And so we can use one medication that may have a very good impact in terms of improving the patient's pain, but also improving their sleep symptoms and improving their mood symptoms as well.
I can give an example in a similar way. We have a database that we use looking at a surgery and different aspects of the actual surgery. One of the things that we look at is blood loss. How much blood loss have we had with surgery? And we know that with our minimally invasive surgery, we have very little blood loss, sometimes not any more than a teaspoon, for instance, compared to some of the much larger surgeries. So, and we can compare our results with other hospitals and throughout the United States. So we know that minimally invasive surgery is the outcomes are just as good, but we have much less blood loss. That's something that has definitely impacted our practice.
It's fascinating. Thank you for sharing that. A couple of questions from the chat that I thought were great here. Shika asks, how long do you typically track a patient's outcome from treatments?
So that's a good question. I think it depends on the treatment. So maybe Dr. Elowitz can speak a little bit more about surgical treatment outcomes. In terms of non-operative or non-surgical treatment, we track it over time, usually no more frequently than once a month. We ask patients to fill out the questionnaires as long as they're continuing treatment at our pain center. But we try to track it long-term because often, unfortunately, low back pain can be recurrent. So sometimes patients feel better, but it may come back in the future. And so we want to try to get some good long-term data because that's what, there is missing in the literature as well.
Yeah, and I think with a surgery database, I wish we were able to track every patient for years and years. We do have one database that many, but not all of our patients are entered into, and those patients are tracked for 2 years. But that's not 100% of patients, but it's at least a snapshot of how we're doing.
Great. Well, thank you for responding to that. Giovanni asked a very interesting question. He says that, is it possible to assess problems that are not primarily pain? So how do we use measures that don't just look like pain impact, but actually functional ability? Maybe you can give an example of one, that you look at in determining baseline and then improvement.
So we look at functioning in a lot of different ways. One functioning is, whether a patient is able to complete their activities of daily living, so pretty basic functioning. Another area that we look at is how long can a patient stand or how far can a patient walk before they're limited. And so those are objective things that we can ask patients and we can track over time and see if those things improve with treatment as well. We often work closely with our physical therapy colleagues and physiatry colleagues as well to track that as also.
And we have specific questions that are asked about activities, function, how the patient may be limited. Could be pain, it could be weakness that's limiting them, as well as quality of life indicators to see overall how someone is progressing.
Maybe you can take a little time. It seems like you collect a lot of really important data. There's a lot of really important and numbers that are being recorded. How do you respect privacy here? Is it something that is tracked by patient name? How do you compile this?
Privacy is clearly paramount. There are HIPAA, which are the federal privacy laws that are respected, by all of us. Everything is entered into a secure, HIPAA-compliant database when it's in a separate system, or it lives in the patient's chart, which of course is also HIPAA-compliant. Any system that we use, we have to make sure we're respecting a patient's privacy. This is not information that is ever released about any individual patient, of course.
And again, with all of the electronic questionnaires that we're doing that are available on MyChart or Weill Cornell Connect, that is a secure platform that links to our secure electronic medical record. And so those are all HIPAA compliant. And then in terms of any database work that we do, we extract some of this data into a registry, but everything is de-identified. So there's no what we call protected health information. So the patient's name, date of birth, et cetera, are all eliminated from the database. And so there's nothing that would identify the patient. And that is all on secure servers as well.
There's a question from Robert that says, how well do you find these procedures being covered by major insurance carriers? And I think that's slightly different than what we're talking about today, but it led me to think about, does this data get shared with insurance? Has it impacted your ability to get things covered by insurance companies or other regulatory bodies that may be involved in patient care?
That's a great question. I've actually met with many insurance companies, and they're very impressed with the type of data that we do collect. Insurance companies, of course, want to know that what they're spending their money on is working. Are they getting value for their money? And of course, are the patients being appropriately treated? And that's one of the reasons why we've become a center of excellence. We've been designated that by Blue Cross. And this is because we have been tracking our data. We can show our quality.
Maybe you can share what is a center of excellence, for those that may not be familiar.
Center of excellence is a designation that many insurance companies have. It's very competitive. There are very few centers of excellence. To my knowledge, we're the only spine center of excellence in New York for Blue Cross. They look at the volume of cases, they look at our outcomes, look at any kind of complications such as infection rate, and they also look at the cost of care. And in order to give that type of designation, kind of like a gold seal.
Lisa, I'm sorry that I might have cut you off. You were also saying something about how this data has been useful for insurance carriers.
I was just going to say, I think it's going to be even more important in the future as more of the care that we provide is quality driven and needs to be evidence based. And so having the data to support what we're doing and to show that the care we provide is helpful and valuable, I think is going to be really important.
Thank you for that. Let me just walk through a couple more of these things here. We've talked about that these are decision-making guides, and it's not just looking at pain, as we talked about. One thing that came up as a question is how long does it take to go through all these questions? If you're a patient, it could be pretty overwhelming, the number of questions that are coming up. And are there ways that the questions are more tailored to what they're experiencing as they fill them out?
So the way it's currently set up is that the new patient intake may take patients around 15 minutes or so to complete electronically. And then the follow-up questionnaires should take about 5 minutes or so, up to 10 minutes at the most. The system is set up that the computer is actually very smart. So the questions that the patient sees is determined by the prior answers. So it depends on how the patient answers the questionnaires in terms of how many questions the patient will actually see. But it tries to allow for a lot of efficiency in terms of completing the questionnaires and getting valid and useful information compared to paper questionnaires where often you have to fill out many more questions.
Have you found that using these questionnaires has allowed you to spend more time on other things, whether it's discussion, questions, counseling? How has it changed the nature of the visit itself during the time that you have together?
We really look at all the information the patient sends us, and I acknowledge to the patient and tell the patient to thank them for filling out our paperwork, because I know it does take time, and many patients spend a lot of time and make sure that it is very, very complete. We find this to be very useful, and you're right, we can then spend more time on finding out information that's not necessarily covered by the questionnaire. But having that as a basis is really critical to help determine a treatment plan for an individual patient, and then overall to tailor a treatment for any particular type of problem.
There was a couple questions that, again, a little bit outside of our topic today, but I thought that they could be addressed in how we use data for this. David earlier asked, does surgery lower the need for pain medication? And another one that came in is, are pain meds given cautiously because of some of the risks that come up from this? And how have you used big data that we've tracked to change how the nature of using some of these potentially dangerous medications?
The issue of the opiate crisis in the United States is really affecting the way that we are treating patients and prescribing medications. One of the goals of surgery is to reduce the amount of pain medication that a patient may be on. If a patient has been on opiate medications, we ultimately want to get them off, or at least to as low a dose as possible. Of course, right around the time of surgery, right after, they may need to increase their dose, particularly in patients where their threshold, their tolerance for pain medication may be different. But we have stopped, at least after surgery, using long-acting opiates, except for very rare cases. So that's something that we have done at our center. Something else that we get is a monthly opiate prescription report. So we know that among our providers who is prescribing opiates, how many times they've prescribed opiates, and how long have they prescribed opiates for individual patients, how many refills that these patients have been on it for weeks or months, so that we know and we could track that information.
And as a pain management physician, you know, opioids, I think, have a role in managing pain, but we also try to use a multimodal strategy. So we try to use a lot of other adjuvant pain medications as well to help manage a patient's pain. And we also try to, you know, prescribe physical therapy and offer interventions or injections, offer referrals for complementary and alternative therapies, things like acupuncture and massage, to help manage the symptoms, not just relying on opioids alone to manage a patient's pain.
Thank you for that. Ruben actually asked a follow-up question to that. Do physicians help wean patients off of pain meds, especially opioids, and include treating withdrawal symptoms? And trying to add a little bit more to that, and how have you used your protocols that you've used in surgery? How soon do patients come off of these meds typically?
Well, some of that really depends on how quickly we can get patients off on whether and how long they've been on opiate medications before surgery. If a patient, for instance, has been on virtually no opiate medication prior to surgery, certainly with the minimally invasive surgery, they are usually off within a matter of days to maybe even a week or two. For the bigger surgeries, we in surgery really rely to a large degree on our pain management colleagues to help with the weaning process, because we know how important that is, particularly if patients have been on opiate medication long term. We will have the patients see pain management before the surgery so that we could better treat their pain while they're in the hospital in the immediate post-operative period, and then to tailor them and taper them down gradually over time. And that's really the importance and value of having a comprehensive spine center as we have at Weill Cornell.
Well, one of the questions that came up is, how important is an MRI? And is there value to repeat MRIs? How do you look at tracking progress? Is there imaging involved in this?
So it depends on, I think, the individual patient. An MRI tells us structurally exactly what's going on. And so while we can get some information from a history, just by speaking with the patient and doing a physical exam, it is helpful structurally to see if, for example, there's a disc herniation pinching the nerve, how severe it is. And definitely before considering any type of interventional therapy, I think it's important to see structurally what's going on, to know that that it's going to be a safe procedure, and to know to choose the most effective treatment strategy for that patient. In terms of following MRIs over time, it's really pretty variable depending on the patient's symptoms. We don't order routine imaging. It'll be dependent on how the patient does with treatment.
Eric, how often do you get repeat imaging, and how do you answer if a patient says, how do I know the disc has gotten better?
We use repeat imaging in certain circumstances. For instance, if a patient had an MRI scan showing a problem such as a herniated disc, and we're considering surgery many months later, we may want to get a new MRI to reevaluate that, because we know that the discs can change within a period of weeks, or certainly over a period of months. After surgery, of course, it depends on the type of surgery. If a patient is doing as well as expected, we won't get a routine MRI just to check. But if a patient is doing well and they may have additional pain at some other point, or there may be any other issues, then of course we would want to get an MRI just to follow and see what's happening, but not necessarily just as a routine.
That's very interesting. Thank you for sharing that. A very kind patient privately messaged me and said, I've had a wonderful experience with the team approach at the Center for Comprehensive Spine Care. What should I do to help express that, and who should I tell?
Well, I'm glad to hear that this patient had a very positive response, and I think that is what our goal is. We want our patients to have good experience. What they should do if they have experiences is to let us know. And there are when patients come in right after they check out, they get a questionnaire. We need to know that. Sometimes even just a note or letter to the doctor. Many patients get surveys as well, particularly after they've been in the hospital for the HCAHPS, and that's something that we look at as well. So there are many ways to express their positive outcome.
And also, we mentioned earlier all of those websites online. If you had a great experience and you'd like to share that on one of those websites, we would always appreciate that as well.
Yeah, as a physician here as well, I can say that it's a very important tool. Patients do use this, and while some may not have always had the best experience, we certainly use the feedback to continuously improve. And so we do welcome that feedback, and we love to hear stories, especially those that are doing well, because this is partly why we went into this field to begin with. So any parting thoughts that as we wrap up here that you'd like to share with patients that are spending their time here about how we track data, where you see the future going with this?
Well, yeah, I think that the fact that we are collecting this data really gives us a lot of information. I think it helps us treat an individual patient. I think all of our goals is to customize a person's treatment and to know what their expectations are. But it also helps us judge ourselves and how are we treating a particular treatment. Is a particular kind of surgery working? Is a particular pain management treatment working? And again, at a comprehensive spine center, such as Weill Cornell, where we have multiple providers, it'll also help us to determine who is best at seeing a particular patient and who's best at treating that patient.
And just to reiterate those comments, we appreciate your time in filling out all of the questionnaires, and understand that it can be lengthy, especially for the new patient intake, but it is really important and does help us tailor our treatment for you. And then also at a population level, it does help us learn, about similar patients for the future, how to best care for chronic pain and spine patients in general.
Well, I want to thank everyone for joining us. A couple of concluding remarks. We are certainly keeping track of what's happening with the coronavirus. Fortunately, in New York, we have seen a nice suppression of cases. But that said, we still take all the precautions, both in your clinic visits and also surgery. And there was a question that came in at the end about whether this is a good time for surgery. The way I would answer that is, if surgery is right for you, it is being done in the safe manner. And I know Dr. Elowitz has operated on a few of my patients, and they've had wonderful outcomes, even as recently. V sends a shout out to you, Dr. Witkin. She really has had a great outcome, and she's thankful. I want to also highlight that there were 3 past topics, like on spine time, that we have performed, and those are available on YouTube. You will see the link in your email, and I welcome you to review those. August 5th will be our next one, where we'll have Dr. Hartle and Dr. Mo Paracha speaking about if you have been selected or if you are undergoing surgery, what should you expect from surgery during that time? We'll be talking about the anesthesia, the preoperative assessments, what happens during the day of surgery, your recovery time in the hospital, and then afterwards. I also did not get a chance to answer all the questions that came up through the chat. And if they were very specific, sometimes it's difficult for us to answer that. So I do welcome you to make an appointment with us and try to get your questions answered specifically. I thank you for all your time. Oh, parting thought for Dr. Elowitz from Carolyn Chester, saying she's doing great from 2015. Wonderful to share that. Thank you for sharing that. So I wish you all a good night, and we hope to see you on the next one.